Okay, we are finally ready to get started after, thanks for hanging in there with those technical issues. Thanks for everyone on Zoom. It should be working now. Text your friends, let them know. So without much further ado, we have Dr. Rachel Dickey, and she is going to be presenting on the very controversial injectable promethazine alternatives, a gut feeling. So welcome her and give her some grace as she's prevailed through these technical issues.
Alrighty, as Brandy said, we are going to be talking about injectable promethazine alternatives, a gut feeling. So I have no disclosures regarding financial or personal relationships regarding this presentation. By the end of this presentation, you should be able to describe historic ISMP and FDA stance on risk associated with the administration of injectable promethazine. You should be able to review the risk profiles of antiemetic classes, select appropriate prophylactic agents for nausea and vomiting based on patient-specific factors, and be able to identify appropriate alternative treatment options for nausea and vomiting while avoiding injectable promethazine. So these are some of the abbreviations that will be throughout this presentation. I will define them as we go through. So first, we have to take it all the way back to the very beginning and understand what promethazine is and what has happened to land us in the position we are today. So promethazine is indicated to treat allergic reactions, motion sickness, postoperative nausea and vomiting, and it is also used as a sedative or an adjunct to analgesics. The IV formulation poses serious safety risks that include severe tissue injury, including extravasation, tissue necrosis, gangrene, and amputation. These risks are with the IV formulation rather than the IM. So theoretically, we could permit IM administration only. However, facilities may find this to be very difficult to enforce because at the bedside in operative spaces, administration can be difficult to track. So we're going to take a little bit of a journey. This timeline is going to come up several times, and we're going to work our way through to give us a better context of the removal of IV promethazine and what has happened throughout history here at Erlanger. So back in 2021, it began with ISMP. ISMP put out a best practice statement that recommended to not administer promethazine IV or IM, and they recommended to eliminate injectable promethazine from formulary. This included removing injectable promethazine from all areas of the organization, including the pharmacy, to classify injectable promethazine as a non-stocked, non-formulary medication. They recommended implementing a medical staff approved automatic therapeutic substitution policy to convert all injectable promethazine orders to another antiemetic. And they recommended removing injectable promethazine from all medication order screens, from all order sets and protocols. This best practice also did include that IM administration as well, because it can accidentally, if it's injected intraarterially, cause these same side effects. In response to ISMP's recommendations in 2021, Erlanger instated some patient safety actions. So Erlanger first started with discouraging use. So all efforts to discourage use of IV promethazine were implemented. Promethazine was removed from adult order panels. They added prochlorperazine as an option to the panels with a provider BPA that fires on ordering, that alerting the use of warnings and recommending prochlorperazine as a first-line alternative. Promethazine vials were removed from all Omnicell cabinets. The max dose of IV promethazine was reduced from 25 milligrams to 12.5 milligrams. And there were administration instructions that were added to the MAR that included dilution and max infusion rates. As we moved further along a little bit later, 2 years later in 2023, FDA instated a guidance update that required updated labeling for all promethazine injection products. These recommendations included deep IM administration as being the preferred route, If intramuscular injection was not possible, promethazine could be given IV, but only in emergencies. And however, that was only after dilution and infused through an intravenous catheter inserted in a large vein, preferably through a central venous catheter. And they recommended not administering it through catheters that were placed in veins that were in hands or wrist. This table right here comes directly from the FDA guidance. It included the dose of promethazine, so some of the recommendations were based upon dose, the volume of normal saline that for dilution for each individual dose, the max concentration of the diluted solution that was the same across all doses, being 1 milligram per ml, and then the max infusion rate. The only one that was different was the highest dose of 75 milligrams. That was the max infusion rate was 5 mLs per minute. So again, in response to another guidance update coming out, Erlanger instated a new EPIC warning in response to these recommendations. This was the warning that EPIC added to populate in EPIC when promethazine was ordered. It gave prochlorperazine as an alternative, as you see in the middle of the screen, that is with the blue box around it. So it gave the reasoning behind this warning popping up. It gave the alternative that could be clicked and ordered, but it still allowed for IV promethazine to be ordered, but it forced the prescriber or whoever was ordering it to make a check and move on from there. So in response to this warning, we wanted to take a look and see what our usage was despite the warning. Despite the warning, beside all of these recommendations removing from cabinets, there were still 7,031 injectable promethazine doses given in 2025. The areas with the highest usage included the ED, OBGYN, and anesthesia. Preliminary conversations revealed that there was provider resistance to removing promethazine from formulary because there was a lack of familiarity with alternatives and they were not really buying into the risks that were associated with IV administration. So surprisingly, despite everything that Erlanger had done up to this point, providers were still resistant to remove it from formulary and there was still high usage within our institution. So we started looking at what other institutions around us had been doing with these new warnings. Park Ridge chose to remove IV promethazine from formulary without consideration for use restriction criteria. CHI Memorial, or now known as Common Spirit, required a central line for the use of IV promethazine, and Emory Hospital had IV promethazine removed from formulary years ago. So this leads us to now. In 2026, back in February 25th, Erlanger has removed IV promethazine from formulary. So now what? Our next step is going to be guiding our providers to alternatives. Part of this is understanding what is available and what is to recommend. So FDA, ISMP are the ones that put out these recommendations to remove it from formulary. So what do they recommend instead? Absolutely nothing. They give no guidance. They take no stance on what should be utilized instead of injectable promethazine. They say remove it. Good luck. So for the remainder of this talk, we are going to review evidence to support pharmacist-guided selection of IV promethazine alternatives. This is going to be our first knowledge check of this presentation. So what recommendation does ISMP make regarding injectable promethazine? So A, monitoring for adverse effects when using. B, restrict the usage to obstetric patients. C, removal from institutional formularies. Or D, update administration instructions for all injectable products. You would be correct. That is C. So ISMP is the one that made the recommendation to remove from institutional formulary. So for our next section of this presentation, we're going to take it back to the basics. First, you have to understand how nausea and vomiting works and what agents are available before we can make recommendations. So first, we're going to take a glance back at nausea and vomiting. So this is a very, very busy slide. It's an overview of the pathophysiology of nausea and vomiting. What is very important to take away here is that there is a lot happening. There's a lot of receptors. There's a lot of different areas that play into nausea and vomiting. So one of the things we're going to see throughout this presentation is that a multimodal approach is going to be the best option for nausea and vomiting because of all of the different receptors and areas that play a role when we are utilizing antiemetic agents. We're next going to review quickly what agents we have in our toolkit for nausea and vomiting. While the focus of this presentation is not a pharmacology review, revisiting these classes is relevant to our theme of agent selection for special populations. First, we're going to look at the phenothiazines. So our phenothiazines include promethazine, which we are removing from formulary, and prochlorperazine, which is our new hospital recommended alternative to promethazine. So promethazine inhibits D2 and M1 receptors and has some H1 inhibition, while prochlorperazine causes D1 and D2 inhibition, along with some chemoreceptor trigger zone depression. So there's a slight difference in their mechanisms of action in this class. So both dosings are here for your reference. Of note, we do still have oral and rectal promethazine. It is just IV and IM that has been removed from formulary. In regards to side effects, both agents in this class have akathisias. These are movement disorders that are characterized by this inner feeling of restlessness accompanied by a mental distress and or the inability to sit still. This is generally more associated with prochlorperazine as compared to promethazine because prochlorperazine inhibits D1 and D2. However, these akathisias are not harmful. They usually go away within a few hours after receiving the dose of either one of these medications. Promethazine is associated with this severe tissue injury that is in red. This is the reason we are removing it from formulary. It also does have some sedation due to that H1 blockage as well. Prochlorperazine has some associated anxiety. However, this is really an anecdotal side effect. There's not too much data on the anxiety that is associated with the prochlorperazine. Some pearls to be aware of specifically for prochlorperazine is that it should not be mixed with isotonic fluids, particularly lactated ringers, due to the risk of precipitation. It should also not be administered as a bolus injection due to the risk of hypotension that comes along giving it as a bolus injection. Our next class of medications are the 5-HT3 antagonist. The two we're going to talk about is ondansetron and granisetron. Ondansetron is dosed at 4 to 8 milligrams every 4 to 8 hours as needed. It does come as an oral agent, an ODT, and comes IV as well. It is a relatively cheap agent that is only 35 cents for a 4 milligram dose. This is the one we do have on formulary here at Erlanger. Some of its side effects include headache, constipation, QTC prolongation. Some of its benefits are that it does have a prolonged duration of about 8 to 12 hours, and it has no renal adjustment with ondansetron. While granisetron is not one we have on formulary here because of the cost difference. So it is $10.80 for a 1 milligram dose, which is right in the middle of the dosing range. Our next group is going to be the anticholinergics. We are going to just talk about two of them that are included in our order panels. So first is diphenhydramine. Diphenhydramine blocks H1 and acetylcholine receptors in the brain. It does have the anticholinergic side effects of drowsiness, sedation, dizziness, headache, and dry mouth. This is a relatively cheap agent at 90 cents for a 50 milligram dose. Most of the time, the dosing for this for an antiemetic is 25 milligrams to 50 milligrams. We also have the scopolamine patch. This blocks acetylcholine receptors in the central nervous system and the peripheral nervous system. Difference from diphenhydramine is this one does have a black box warning for hyperthermia. It does carry all the same anticholinergic side effects of sedation, drowsiness, dizziness, headache, and dry mouth. This one is slightly more expensive at $6.60 for one patch, but the patch lasts for 24 hours. Our next class is going to be the dopamine antagonist. The three that we are going to talk about is haloperidol, droperidol, and amylopride. So amylopride in particular is our brand new agent. It has a unique mechanism of action, and it has a unique place in therapy where it is approved to be used for rescue treatment after failed prophylaxis with antiemetics is given. So looking at their mechanism of actions first, haloperidol and droperidol are non-selective for the dopamine receptors, while amylopride, its new mechanism of action is it's selective for D2 and D3. Both haloperidol and droperidol have side effects of QTC prolongation, which is what makes them not first line for antiemetic therapy. However, droperidol does carry a black box warning for arrhythmias and a risk of sudden cardiac death. However, there is a new stance that has come out with droperidol that the QTC prolongation is not as severe as previously thought that instated that black box warning. At doses for post-op nausea and vomiting, the QTC prolongation is similar to that of ondansetron. Amylopride does not have this QTC prolongation that the other two have. It does have a side effect of insomnia. What makes amylopride unique in its dosing is that haloperidol and droperidol are given just as one-time doses, whereas amylopride's new place is that it can be redosed. So it can be given as a prophylactic dose, and then if they continue to have nausea and vomiting after receiving prophylaxis, it can be given as a treatment dose. However, what really applies here is the big cost difference. So haloperidol is 51 cents for a 1 ml vial, whereas droperidol is $6.68 for a 1 ml vial. And amylopride is $28.62 for a 2 ml vial of amylopride. So when talking about what we have in our toolkit and what we have on formulary, we have haloperidol. The reason we have it over the other two is due to cost. The black box warning, QTC prolongation with droperidol is not the reason we don't have it. It just is significantly more expensive than haloperidol, and amylopride is much more expensive than the other two as well. Amylopride is a very attractive agent to anesthesia. They have actually already asked for this agent and have been told no, because while it is a very great and unique medication, the cost really limits its use here at Erlanger. So if you do get asked for this agent, we do not have it, but the agent you could recommend instead that's in the same class is haloperidol. So we are going to move on to our neurokinin 1 receptor antagonist. This class includes fosaprepitant and aprepitant. These are very attractive agents because they have a lack of sedation and side effects as compared to some of the other medications that we use as antiemetics. These drugs have a long duration of action. The oral agent has a half-life of about 40 hours. They have improved efficacy as compared to ondansetron, and they have a lack of sedation. However, some of the side effects include headache and constipation, and the oral form in particular has some severe drug interactions, particularly with like warfarin and our hormonal contraceptives. Fosaprepitant is the IV formulation. It's given as a 150 milligram dose that's just given one time because of the long half-life, and it is $20.89 per dose, where aprepitant is the oral form, and it's given as an 80 milligram dose. That is $125.36 per dose. So fosaprepitant we do have on formulary. However, it is restricted to gastric surgery and neurosurgery. So this restriction criteria is that when you try to order fosaprepitant in Epic, this restriction criteria does pop up. So if you do get a call asking for either IV amend or fosaprepitant, it is restricted to these two areas only. You can also just say no. Our last two that we're going to talk about in our class review is dexamethasone and metoclopramide. These are two of our ancillary therapies that are generally added last. So dexamethasone is recommended dose for post-op nausea and vomiting is 4 to 8 milligrams once. It is one of 5 most effective single drugs for post-op nausea and vomiting prevention as recommended in the guidelines. It does have a side effect of hyperglycemia. Where metoclopramide is a 10 milligram IV dose that's just dosed one time. It is a relatively cheap drug at 91 cents for 10 milligrams. However, it's generally not recommended for post-op nausea and vomiting prophylaxis because it has shown to not be as effective as some of our other antiemetic agents. So this is going to be our next knowledge check in this presentation. So which antiemetic medication has a risk of akathisias? So A, prochlorperazine, B, ondansetron, C, haloperidol, or D, fosaprepitant. You would be correct. It is A. Prochlorperazine is our antiemetic that carries that risk of akathisias, and we are going to follow this throughout our presentation. So we are going to move on to the individualized therapy section of this presentation. There are two main categories in which we use antiemetic agents. So we use them for prevention of nausea and vomiting, and we use them for treatment of nausea and vomiting. So we're first going to start with prophylaxis. In the prophylactic section, we have two main buckets. We have post-op nausea and vomiting, which is also called PONV, and we have chemotherapy. Due to time constraints, we are really only going to focus on PONV or post-op nausea and vomiting. The targets for this population are surgical patients. There are certain types of surgeries that have higher rates of post-op nausea and vomiting. These include bariatric surgeries, laparoscopic cholecystectomy, urological procedures, our gynecologic and obstetric surgeries. Did you know there is a scoring tool to help stratify patients at risk for post-op nausea and vomiting? The post-op nausea and vomiting risk assessment tools and risk stratification protocols are effective in reducing post-op nausea and vomiting. These risk scores can help inform and guide therapy. They can reduce institutional levels of post-op nausea and vomiting rates, particularly using this APFEL simplified score for risk stratification. This particular APFEL score predicts the risk of post-op nausea and vomiting based on 4 different factors. So female gender, non-smoker, history of post-op nausea and vomiting and/or motion sickness, and post-operative opioid use. Each risk factor gets a point for the score. The score is from 0 to 4. And the scores 0, 1, 2, 3, and 4 correspond with post-op nausea and vomiting risk of 10%, 20%, 40, 60, and 80%. So those that have all 4 risk factors are at an 80% risk of developing post-op nausea and vomiting. This particular scoring tool is included in our perioperative nausea and vomiting order panel that can help our providers select therapy and guide the number of agents they are going to give. So when they go to order our antiemetic agents in our perioperative order set, this is what pops up. So if you have a question this would be helpful for, this is a great resource to utilize. But also, did you know there are guidelines for this as well? The ASHP post-op nausea and vomiting prophylactic guidelines were updated in 2025. The main approach in these guidelines is multimodal therapy. This general statement recommends that you administer at least 2 interventions for any risk of post-op nausea and vomiting. So if they have at least 1 point, you're going to do at least 2 agents. Of note, these guidelines do not acknowledge ISMP's recommendation to avoid the use of IV promethazine, except for in emergencies. Because no single class or drug is completely effective for prophylaxis, if you think back to our pathophysiology of nausea and vomiting with all of those receptors, all of those areas, that makes not one agent, one class completely effective. Research shows that multimodal prophylaxis reduces post-op nausea and vomiting incidence. So with a focus on this multimodal therapy, selection is going to be based upon that perioperative risk with that APFEL score. So the APFEL score, particularly those points, help us determine the number of agents that should be utilized that may be needed for these patients. So if they have no risk factors at all, they don't have any of those 4 points, that would be when you would utilize 1 agent. If they have 1 to 2 risk factors, at least 2 agents, and then 3 or more risk factors, using 3 or 4 agents. There is an importance of guideline-based therapy selection since post-op vomiting increases the risk of aspiration, delayed transfers from the PACU, delays in throughput and discharge for patients. It goes beyond just our patients feeling uncomfortable. There are actual metrics that this does play a role in. So to tie what we've talked about all together, here are the options that we currently have on formulary that can be used for this multimodal approach to post-op nausea and vomiting. However, these are the agents that the guidelines recommend as the most effective. They are the A1 rated drugs in the guidelines for post-op nausea and vomiting. The three in bold are currently ones that we do have on formulary here. So we have dexamethasone, haloperidol, and ondansetron. This is going to bring us to our first study of this presentation. As providing evidence-based context for recommendations, we're going to review evidence together that provides support for using our new alternative, particularly in high-risk surgical patients. This particular study compares our new hospital-preferred alternative agent, prochlorperazine, to a guideline A1 rated drug, ondansetron, that is also on formulary here. It does so in patients undergoing laparoscopic cholecystectomy, which is one of the higher risk procedures for post-op nausea and vomiting. This is a randomized control trial that has 126 patients that was completed from January 1st, 2020 to June 30th, 2020. The primary outcome was the frequency of nausea and vomiting 24 hours post-operatively. Patients were given either ondansetron 4 milligrams or prochlorperazine 10 milligrams once prior to the induction of anesthesia. So the efficacy of doses was examined at 24 hours after surgery, and it compared the frequency of nausea and vomiting between both groups. So it looked at nausea and vomiting as two separate outcomes in the ondansetron group and the prochlorperazine group. There were an equal number of patients between the two groups. The study showed that there was no significant difference between either group regarding the incidence of nausea and vomiting. In the ondansetron group, starting all the way out here on this side, there were 8 patients that had nausea while 11 had vomiting compared to 10 patients with nausea in prochlorperazine group and 7 with vomiting. So the authors concluded that ondansetron and prochlorperazine are both effective for preventing post-operative nausea and vomiting for laparoscopic cholecystectomy. A limitation of this study was that it was a fairly small study that did not meet power, and it was a niche patient population that did exclude patients with a history of post-operative nausea and vomiting. But the main takeaway from this study is that our new alternative is going to be unfamiliar to our prescribers, but there is sound evidence for efficacy and safety, even in patients undergoing a procedure that is considered to be a high-risk post-operative nausea and vomiting procedure. To wrap up this section, looking specifically at prophylaxis for post-op nausea and vomiting, some things to take away are that pharmacists can recommend our new promethazine alternative, prochlorperazine, based on limited data of efficacy in surgical populations. And pharmacists should be aware that the multimodal approach to therapy is preferred in our post-op nausea and vomiting prophylaxis population, and to be aware of the formulary agents that are available to be utilized in combination for these patients. So for our next knowledge check, which population has a validated scoring tool to evaluate the risk of nausea and vomiting that guides the number of agents utilized? So A, OBGYN, B, ED, C, post-op nausea and vomiting or PONV, or D, chemotherapy. You are correct. It is C. It's the post-op nausea and vomiting population that has the validated APFEL scoring tool. Now we're going to shift gears a bit. We're going to move on to treatment. There are several populations that antiemetic selection is going to be important. So we are first going to focus on rescue therapy in the setting of post-operative nausea and vomiting. So we've discussed previously the prophylactic agents for post-op nausea and vomiting. But what should you do when a patient has received prophylactic agents for prior to their surgery and they proceed to have nausea and vomiting despite receiving these agents? This on the table on the screen includes the agents that are considered to be the best agents for rescue treatment. So first line being our ondansetron, second line prochlorperazine, third line haloperidol, and then rescue beyond those is our amslopride and our metoclopramide. However, of note, amslopride is not formulary here at Erlanger and very, very expensive. There remains a paucity of published evidence on post-op nausea and vomiting rescue treatment. This presents a challenge in developing evidence-based guidelines or recommendations on the optimal agent, the dose, the route, tolerability, and safety profile. It may be tempting to assume that the drugs that are the most effective for post-op nausea and vomiting prophylaxis would also be as effective for treatment. However, such approach is not without its limitations. Patients should receive rescue treatment from a different pharmacologic class to the prophylactic agents administered. Redosing should only happen if an inadequate dose was given initially or if it has been greater than 6 hours since the administration of the first agent. Or you can consider redosing if no other alternatives are available. Of note are very long-acting agents, so our fosaprepitant or aprepitant that had the half-life of about 40 hours should not be redosed in the PACU. The major takeaway from this is that we should avoid reusing the agents that were already used for prophylaxis. So if they have already gotten one particular agent, choosing something from a different class is going to be more effective than redosing that same agent. So for the next section of treatment of nausea and vomiting, we are going to look at some common populations that should give some providers pause when choosing antiemetic agents. The first group we are going to look at is our uncomplicated nausea and vomiting population. This is particularly seen in the emergency department. Uncomplicated nausea and vomiting refers to a condition where the patient experiences nausea and vomiting, but does not have systemic symptoms or complications that require further medical intervention. In contrast, complicated nausea and vomiting involves conditions that may require extensive evaluation, multiple treatment options, or systemic symptoms, indicating a higher risk of morbidity or complications. In uncomplicated nausea and vomiting, we have pretty much everything in our toolkit to use that we have here currently on formulary. So these are all of our formulary agents that are antiemetics, except for what is not included here is fosaprepitant because it is restricted. This is the place in therapy selection that our selection should be guided by the knowledge of relative efficacy and individualized patient assessment or comorbidities. So like I said, a major place we see uncomplicated nausea and vomiting is particularly in the ED. This study is a randomized double-blind comparison of prochlorperazine, so our new hospital alternative, and promethazine, what we have removed from formulary for acute ED treatment of uncomplicated nausea and vomiting, secondary to gastritis and gastroenteritis. The purpose of this study was to compare the effectiveness of prochlorperazine and promethazine, thought to be for nausea and vomiting, thought to be secondary to uncomplicated gastritis or gastroenteritis. That was defined as the presence of acute nausea and vomiting with or without diarrhea and had no localized abdominal pain or any other known underlying causes of their condition. The main outcome measure was a degree of relief at 30 and 60 minutes. They looked at vomiting duration, number of times vomiting, the amount of vomit, the presence of blood, dry heaves, evidence of dehydration or diarrhea. All of these were recorded outcomes. The presence of dehydration was defined as the presence of one of the following having a dry mucous membrane, low blood pressure, orthostatic changes, dizziness, or decreased urine output. So subjects were directly asked about their nausea, and they ranked the amount according to the visual analog scale, or the VAS, as you will see up on our next slide, at baseline, 30 minutes, and 60 minutes. They also recorded the need for further antiemetic agents, intravenous fluids used and the amount, their time to complete relief, and adverse effects such as drowsiness and dizziness. The time to complete relief was placed into 3 categories: 0 to 30 minutes, 30 to 60, and beyond 60 minutes. They defined a treatment failure as needing further antiemetic agents after treatment for recurrent or persistent nausea with or without vomiting. So they were considered to be a failure if they needed beyond this dose of either prochlorperazine at 10 milligrams IV or promethazine 25 milligrams IV. So this is one of their first outcomes. So this particularly was looking at their visual analog scale rating at baseline 30 minutes and 60 minutes in both groups. There was no difference in the visual analog scale readings at time 0. 30 minutes after receiving the medication, the visual analog scale ratings were significantly better for the prochlorperazine group as compared to the promethazine group. At 60 minutes, prochlorperazine was again superior in the visual analog scale ratings. So the authors concluded that the visual analog scale ratings were significantly better for prochlorperazine group at 30 minutes and at 60 minutes. In regards to time to relief, they looked at from 0 to 30 minutes, 30 to 60, and then beyond 60, and then our treatment failures of needing further antiemetic treatment beyond these doses. Prochlorperazine only had 16.7% of their patients needing greater or resolving their nausea taking more than 60 minutes, compared to 35.7% in the promethazine group. So that was looking particularly at beyond 60 minutes. It was 35.7% in promethazine versus 16.7% in prochlorperazine groups. And then in regards to treatment failures, 31% were treatment failures in the promethazine group as compared to 9.5% were treatment failures in the prochlorperazine group. So the authors concluded that the time to complete relief was shorter for prochlorperazine as compared to promethazine. The last thing that they looked at were particularly drowsiness and akathisias, which are both considered to be side effects that are associated with either one of these medications. Prochlorperazine was significantly more effective in treating nausea and vomiting compared to gastritis or gastroenteritis. In this particular group, they were looking at the side effects. So slightly fewer patients experienced drowsiness in the prochlorperazine group, and akathisias were equal in both groups. So there were exactly the same of akathisias in both groups, where drowsiness was more in the promethazine group. So wrapping all of this together, the authors concluded that promethazine was more effective in treating nausea and vomiting with no difference in frequency of akathisias and less sedation than promethazine. What is important to note of this study was that this was a small study. There were not many patients in either group, and that the visual analog scale may not be the best for time to relief because it is a very subjective scale to utilize. However, this study does give us some reassurance as we're making the switch from promethazine to prochlorperazine. Because of the effectiveness, it was slightly more effective in the study compared to promethazine, and the side effects were very similar or actually slightly better than the promethazine. Our next special population we are going to take a look at is our pregnancy population. Historically, IV promethazine has been a go-to for nausea and vomiting in our pregnant population, so alternatives are especially needed in this area. Recommendations, particularly for pregnancy, are to try one antiemetic after another rather than stacking them on. This particular table includes the agents that are recommended in the American College of Gastroenterology guidelines, particularly for pregnancy. They are considered to be safe in pregnancy. These are the old pregnancy categories, but these were what were utilized when the guidelines were published. This area is particularly important because nausea and vomiting is common in the first trimester of pregnancy. It affects about 90% of women that are pregnant. If drug treatment is needed, antihistamines, including doxylamine and then diphenhydramine, which we have on formulary here, are efficacious without an increased risk of congenital malformations. These are typically utilized first, and most of the time they're utilized outpatient. One big difference in this particular population is if you jump to the third agent down, metoclopramide, we talked about before how it is shown to not be as effective in our postoperative nausea and vomiting population. However, it is one of the preferred agents in pregnancy because it is effective with no increased risk of congenital malformations, spontaneous abortion, or reduced birth weight. And it may be preferred to because of its more favorable adverse effects profile than our pheothioazines, which are the prochlorperazine and promethazine. The use of ondansetron in pregnancy has been increasing. However, it does have limited safety data. There was a 2018 study reported that showed no increased risk of cardiac malformations, but there was a slight increased risk of oral cleft defects. Because the focus of this presentation is our alternatives for promethazine, in this pregnancy section, we're going to take a moment to really focus on prochlorperazine, since it is our hospital's new alternative to promethazine. We want to be able to give you the tools to answer questions of its use in pregnancy. So when you're going through and looking at these medications, the first thing that pops up when you look up prochlorperazine in pregnancy is that it's a category C with teratogenic effects. However, because it is labeled a category C, that is due to it at doses way over the maximum recommended dose. There was some teratogenic effects only in rat studies. However, these risks are clinically insignificant at FDA recommended doses of 5 to 10 milligrams. In excessive doses, at those really, really high doses beyond the recommended max, there are some EPS side effects that can transfer to the neonate if it's utilized in the third trimester, but again, at those toxic doses. In pregnancy, prochlorperazine is recommended as one of the first-line agents for moderate to severe nausea and vomiting, and second line for persistent symptoms when you're having to redose. Our final population that we are going to dig a little deeper into is our cardiac disease population. In this particular population, so there are some very big things to consider. So first being, are they on multiple QTC prolonging agents? Are they on multiple antiemetics? Do we have other antipsychotics that have our QTC prolongation? Do they have a baseline QT that is greater than 500? Or in some other cases, some people will say 550. You're going to see a little bit, there was an article that chose 470 as their cutoff. So what is their baseline QT? And also need to consider, do they have other risk factors for torsades? Do they have a long QT syndrome that's inherited? Do they have heart disease? Are they female over the age of 65? Do they have any electrolyte imbalances? Do they have a slow heart rate? Are they on other medications that could prolong this QT? This was a particular population that I dug for a very long period of time in trying to find hard cutoffs, like what should we cut off our QT for? How much does each agent add to the QT? And really, there's not much data in comparison of these agents in regards to prolonging QT. It generally comes down to the relative risk and the comfortability of the prescriber. In practice, I've heard cutoffs of 500. I also sidebarred for a TT pro tip. Some people use a 550 as their cutoff. However, there is one article that has been published in a palliative care population that where these red, yellow, and green categories I have pulled from. This particular article looked at the risk of QTC prolongation of certain agents. They used a cutoff of 470 as their cutoff for not going beyond for a baseline QT. But this was in a particularly frail population that were already at a much higher risk. So this particular article gives recommendations for choosing antiemetic agents in the palliative care population. For patients who do not have any risk factors for a QTC prolongation, such as having a normal baseline QT interval, a lack of drug interactions, renal or hepatic impairment, or don't have any cardiac or electrolyte abnormalities, any of these above pharmacologic classes may be options for these patients. So I used a red, yellow, green system here. So the red agents are the highest relative risk of QT prolongation of the agents that were mentioned in this article. This included our 5-HT3 receptor antagonists, or ondansetron. Ondansetron seemed to have one of the highest, or one was the highest of considered to be relative risk for prolonging QT. Metoclopramide was included in this category as well as dopamine antagonists, particularly IV haloperidol was mentioned as one of the highest risk for QTC prolongation. And prochlorperazine, our new hospital alternative, is also in this red category. For these agents in the red category, they recommend that if the baseline QT is greater than 470 and or there are other risk factors for QTC prolongation, they recommended choosing something outside of this category if feasible. So moving on to our yellow or green category. Diphenhydramine was the only one that fell into this middle yellow category because it does have some QTC prolongation, but only at toxic doses. So it was recommended in this study that to have close monitoring of the EKG and if the baseline exceeds 500 to either have closer follow-up or choosing something from the green category. However, the only thing that's in the green category is our neurokinin-1 antagonist. These are our really expensive agents that are restricted. So it is not feasible here to choose something from this category. However, in this category, it's because they do not have any QTC prolongation, which makes them a very appealing agent for certain providers if you are able to get this medication. So as we wrap up our cardiac disease, some things to take away. It's really about the comfortability of the prescriber, of you, as you are choosing what kind of those QT cutoffs. It's very important to know which agents cause QTC prolongation and what is the relative risk, looking at the patient as a whole. So that's going to lead us to our final knowledge check of this presentation. So you receive a call from a provider asking for recommendations of what to give for a patient that is vomiting. They have not responded to ondansetron IV 4 milligrams. What information would you like to know from them? A, their pregnancy status. B, cardiac history and or their baseline QT. C, suspected etiology of their vomiting. And D, what has actually been tried already. Oh. Trick check, yeah. It is all of the above. Yes. So from these patients, there is so many different factors that you are wanting to know as you are making this recommendation. So pregnancy status, what is their cardiac history? What is their baseline QT? Do they have what is causing the vomiting? And then what has already been tried as for antiemetic agents? So to wrap us up today for this presentation, Erlanger formulary has removed injectable promethazine, and that was prompted by the severe vascular injury that is caused with the utilization of this agent. Pharmacists should familiarize themselves with formulary alternatives, including the relative efficacy and the risk associated with antiemetic agents. And pharmacists' knowledge of considerations for special populations is key to individualizing therapy for nausea and vomiting. With that, what questions do you have? Oh, Tia.
That is not recommended to when the treatment already happened. At that school, one of my providers was very strongly that program is no longer.
I'm actually going to back up to a slide. So let me just reiterate your question. So once a patient is vomiting, is there an agent that is preferred or should not be continued? So that is that's a really good question. Actually, there is not much on really what tells us if there are preferred agents post treatment. I have seen some anecdotal information that once they are vomiting, nothing's going to be effective. Sometimes it makes us feel better, makes the patients feel better for them to receive an agent. These are the agents. So if they are already vomiting and they have received prophylaxis, these were considered to be our first line agents. I think it also just comes down to the patient specific factors. If it's something that you are concerned about a QT, I would choose a different agent that doesn't have as much QTC prolongation. I think it comes down to those patient specific factors. Yes. Yeah.
I also have a question that arthritis was very strongly that obviously must be given with it cannot get obviously without right reason.
So the question was about utilizing prochlorperazine and diphenhydramine together. There is a provider that feels very strongly that they should be. So the thought behind using Benadryl with prochlorperazine is the risk of akathisias that come with prochlorperazine. Those are at greatest risk when you are using above 10 milligrams. Most of the time we are using 5 to 10 milligrams. The current recommendation right now for utilizing Benadryl with prochlorperazine is if you are at those really high doses and you are very concerned that they are going to have akathisias, you can pre-treat with Benadryl if they have had akathisias in the past. However, these akathisias, they're not harmful. They are uncomfortable. They do go away after a few hours. So it wouldn't necessarily hurt to go ahead and pre-treat with the diphenhydramine because it may also help with the nausea and vomiting. It may not hurt, but that is, you are giving another medication in those scenarios. Emily? So the question was, do I know why it is restricted? IV amend is restricted to neurosurgery and is it? Yeah, bariatrics. The one thing I have gathered from Brittany on that was that it is very expensive and it is due to cost. That would be something I would have to look into further. I do not know why those were specifically the two populations that was selected. Ed?
Of the 7,000 given last year.
Mhm.
Yeah.
I do not have that information for how many reactions we have had. They're very hard to like quantify. That was some of the reason that our providers felt very strongly that we should not remove it from formulary was because we really don't have that data because it's like hard to pinpoint it down to our particular use of promethazine. So we really were just going based off of that guidance. So that was kind of some of the pushback that was given. Oh, that's the important part. Hold on. I was like, well, I completely forgot that. And here is our CE code.